this is a common problem, and on most occasions the hemoptysis is not very much, in which case it just tells you that we are dealing with some kind of endobronchial disease. But other than that, the management part is fairly straightforward and usually responds to conservative treatment. But sometimes the presentation can be dramatic, which means that the patient can have a severe or a massive hemoptysis, and then that can throw up fairly important diagnostic challenges, and then it requires a flexibility in your approach, where otherwise you would have the opportunity of just doing a x-ray and a CT and then going for a bronchoscopy and then planning your treatment. If the patient has got a massive hemoptysis, sometimes you have to reverse the order and straight away step in and do your intervention, control the problem, and then think about the other diagnostic modalities later. Everything also depends on the patient's condition, how sick or not sick he is. If he's fairly stable, he's got a good cough reflex, he's able to cough out the secretions and the blood which is accumulating in his lungs, then it's good. But if he's unable to do that, then that can also hamper your treatment plan. So basically, sometimes everything will have to go hand in hand. Now, the hemoptysis, the definition of hemoptysis, how much it is, has been very kind of varied. So in the literature, you will find all kinds of things. But for practical purposes, if the amount of hemoptysis is less than about 100 ml in about 24 hours, then we put it as mild. Anything more than that will go into the severe or massive category. What you have to realize is that the patients normally don't die of exsanguination. They die of asphyxiation, because if you remember from physiology, the dead space of the lung is only about 150 ml. So 100 to 150 ml of blood, if it occurs suddenly, that is enough to choke the patient and completely fill up all the airways, and that the patient will die. So the severity of the hemoptysis also depends on how quickly the hemoptysis is occurring and how quickly the patient is able to cough out that secretion or the blood. If he's able to cough it out continuously, then usually the problem in management is not so much. How does it occur? Well, mostly these tumors are neovascularized, and serious bleeding is usually from the bronchial circulation. We know that the lung has got a dual circulation, the pulmonary and the bronchial circulation. And the bronchial circulation is what is there at the systemic pressure level, which means that your normal blood pressure level is there in the bronchial circulation. And therefore, if a patient bleeds from that, he's likely to have a brisk and severe hemoptysis. So the tumor surface can exfoliate, it can necrose, there can be an ulceration of the tumor by cough, there can be erosion of the airways, surrounding airways and the vascular structures. And sometimes we, increase the bleeding by doing a procedure, say after a biopsy or after a debulking procedure, and the patient may have a profuse bleeding after that. We also know that the squamous cell histology is the one which, bleeds more often. And especially if the tumor is cavitating, that should make you think that this patient can bleed. The initial evaluation of these patients obviously always therefore involves the ability of the patient to protect his airway, manage his secretions, cough out, etc. And then also how much he is able to cooperate with the diagnosis, especially, for example, bronchoscopy. What is the time of onset? What is the estimated volume of blood? What are the previous similar episodes? Sentinel bleeding may be there. So a patient may have a small amount of hemoptysis, streaky hemoptysis for a few days, and then suddenly have a massive hemoptysis. Is the patient on any blood thinners? Is the patient on any, has any procedure been done? Any systemic therapy has been done which can induce bleeding? Any extra pulmonary cause of bleeding is there. So if the patient in failure, if the patient has got some kind of a, valvular issue or an AV malformation or something. And then, you do the usual labs, you will do a coagulation profile, look at his, hemoglobin, get a grouping cross-matching done, get an LFT, KFT, etc., and an ABG to tell you where the patient stands. Now, to try to find out where the bleeding is coming from and what is causing the bleeding, usually the imaging is what helps you the most. So normally a chest X-ray would be done. It gives you an idea most of the times as to which side the bleeding might be from, and it will help you in guide further testing. But you remember that the X-ray can be normal in about 25% of cases. The CT is invaluable in localizing site and etiology. So CT, if you've got time and the patient is stable enough, you do a CT, it will tell you a lot because it will tell you about the mediastinum, the lung parenchyma, the airway. And if you do a 2D, 3D reconstruction, you can also, get help in guiding interventions. In patients with normal X-ray, the CT can identify the underlying, cancer in about 96% of cases. Even bronchoscopy doesn't match up with that. Bronchoscopy might be able to find out only about 50% of cases. So, as I said, the CT, if the patient is stable enough, then always you must get a CT done, a contrast CT. Then bronchoscopy, it's an important method of diagnosis, localization of the hemoptysis. Now, the advantages of bronchoscopy, of course, are that not only are you able to evaluate the bronchial lesions, but you're also able to plan for the treatment. You can instill drugs, so you can instill drugs to, allay the hemoptysis, for example, adrenaline, cold saline. Then you can also do endobronchial therapy. So in the same sitting, you may consider doing a APC, an argon plasma coagulation, or do a debulking procedure if you are able to do it in your OT in the same sitting. It will help you to localize the bleeding in about, as I said, in about 50% cases, even in normal X-rays. But then it can go up higher, and in more skilled hands, you will be able to get better results. So bronchoscopy, you may, for example, see a bronchial adenoma, you may see an endobronchial tumor, and in patients with normal chest X-ray, also, if possible, after a CT, you should do a bronchoscopy in finding out how you have to plan the further treatment. In massive hemoptysis, mind you, the fiber optic bronchoscopy often enough becomes useless because there's so much of blood inside that you are not able to see, and the small, kind of viewing area of the fiber optic bronchoscope quickly gets sort of soiled and you can't see very much. So a rigid bronchoscope is very important. If you are able to do a rigid bronchoscopy, then that is much more helpful in massive hemoptysis. If you have to do it with the fiber optic, then it's better to put an endotracheal tube and do it through that, because then you are able to at least take out your scope quickly and clean it and put it in again, and also at the same time you are able to ventilate the patient if necessary. So this is an example of a patient wherein through an endotracheal tube we are going in and taking some having a look inside. This is a video lent to us by one of my friends, Dr. Ravi Mehta from Bangalore. And in such issues, because of the disadvantage of the fiber optic and also because of the delay in definitive treatment, the hypoxemia, etc., you may want to do a rigid bronchoscopy, as I said first. Sometimes the bleeding will occur while the bronchoscopy is being done. At that time, first and foremost, some rules are there. Do not withdraw your bronchoscope from the bleeding area. Be there, turn the patient on the side of the bleeding, use suction to take out the active bleeding, instill cold saline repeatedly. You may use adrenaline solution also diluted. Call for help, because sometimes you can lose these patients. So call for help, start IV fluids. If a clot forms, don't suck further. If the clot is forming, very good, let the clot form, let the bleeding be stopped with the clot, and then proceed to do whatever else you have to do. Sometimes better to just let the clot form, leave it there, and then take it up the next day after you've got everything else in place. If the bleeding continues, then you put in a blocker, which would mean usually a balloon. So normally we use a CRE balloon or a Fogarty balloon and put the balloon inside and inflate it in the main stem bronchus to tamponade the bleeding and also not allow the blood to go on to the normal side and cause problem. If significant of blood has gone onto the normal side, then either with another bronchoscope or at least you put in an endotracheal tube alongside your bronchoscope, which is already inside, and with the balloon, and through the endotracheal tube, now you ventilate the patient and also get the blood from the other side and clean up the lung and do a proper suction. So the endobronchial balloon, as I said, tamponades the bleeding. You can do it for prolonged periods, so you can do it up to 24 to 36, 48 hours. It helps you to plan. Aage kya karna hai? So that would mean that if you want to do surgery, you may go for surgery. If you want to do a bronchial artery embolization, which is much more often than surgery, then you may consider, sending the patient for a bronchial artery embolization. And this ballooning gives you time for all that. So these are the type of balloons that are there. You can see the Fogarty balloons here, the CRE balloons, and you can see a patient here with the balloon inside, and you can clip the balloon on the outside so that you can remove your syringe from that. Then the other thing is that during while you're doing all this, you may also have to ventilate the patient because the airway has to be there. So an endotracheal tube is usually passed inside. The same endotracheal tube can also be, put into the normal lung, and therefore you get a isolation of the lung. Other things which have been done, tranexamic acid, you can instill that and it's reported to be effective. You can also use biocompatible glue. So we use N-butyryl cyanoacrylate in mild to moderate bleeding. Then spigot can be placed inside the, the segment or the subsegment where the bleeding has occurred. So some examples, this is a patient where you have a patient with bleeding from the right lower lobe, and an APC will be done. You can see here, this is a APC being fired onto the area of bleeding. And once the APC is fired, the bleeding immediately stops. You can see here how the bleeding is stopping. And then that gives you time to, think further and do whatever you have to. This is a patient again with right lower lobe. This is from slide from Bangalore. So glue being instilled into that particular segment, which is subsegment, which is bleeding. So this glue becomes like sort of cement immediately. Another patient with bleeding from the left, and you can see a rigid bronchoscope is there, and a spigot is being placed inside. You can see here a spigot which has been fashioned out of a used tent that is being put inside, and this is blocking the bleeding. So these are all examples of endobronchial blockers. And the other thing which can be done is a hemostatic sort of therapy with oxidized regenerated cellulose mesh. So Surgicel has also been used in the similar fashion, stuffing it into the segment which is causing bleeding. Then unilateral lung intubation, as I said, if you've got the endotracheal tube, the tube itself, suppose the patient is bleeding from the left side, you pass the tube onto the right side. So here is an example. This is the patient with an endotracheal tube. So bleeding is from the right side here. So the endotracheal tube has been passed onto the left side, balloon inflated. So you are able to at least isolate the normal lung. While this bleeding clots and gets tamponaded here, you are able to at least ventilate your patient, and that again gives you time in patients with massive hemoptysis. The
Sorry,
other possibilities,
Dr. Rajiv, we
yeah,
need to wind up.
we need to wind up. All right. So
Yes.
I guess if you want me to stop, then I'll just stop here because there are several other slides to be shown. But if you want me
Okay.
to stop, I'll
If you
stop.
can conclude, quickly.
I'll try to do that. So this, you can use a Fogarty catheter for the same as I was showing you. This is an ANT blocker, which is a blocking device, which can be used also similarly to the Fogarty balloon. This is a balloon at the tip, and it can be, you can ventilate as well as do bronchoscopy at the same time. These are the kind of clots you can get out. So you can get these clots out either with slow probe or with rigid bronchoscopy. Then endobronchial brachytherapy has been used to good effect, at least for mild bleeding. Then bronchial artery embolization. I think this is the main sort of stay of what you use nowadays for massive hemoptysis, even more than bronchoscopy. I think it is very effective. An arteriogram is performed by femoral artery cannulation. These are the various embolic agents that can be put in. And the literature shows that it is a fairly effective technically, clinically, and the recurrence rates are there. But again, it gives you time for other therapies to step in. And this is a case of a 55-year-old with squamous cell carcinoma. You can see here big tumor blush where the bleeding was there. And then once the bronchial artery embolization has been done, you can see the bronchial artery has been completely blocked here with coils, and the patient has done well. So very effective in controlling acute massive hemoptysis, long-term success rates of about 10 to 50%. And the complications are not very much. In expert hands, complications like spinal artery thrombosis, etc., do not occur. And surgery, of course, is reserved for very few people, where patients who've got localized lesions can be taken up for surgery. In massive hemoptysis, BAE is the way to go. And usually this will be the flow chart. Massive hemoptysis, you do a evaluation, you rule out a gastrointestinal source, go into the airway, make sure that the lung is sort of protected, patient is adequately resuscitated, do a CT, find out more. If the patient is stable, try the other, methodologies. While if he's unstable, you go for BAE and surgery if nothing else works. Thank you very much.